years, but in the Iwama tradition. And I've been a dilettante for probably the last 5 years, so I'm not practicing real seriously. Peterson Sensei asked me to come and give a little talk on first aid in the dojo, something that's specific and germane to us. Background for myself, I'm a registered nurse. I work down at Eisenhower. I've done emergency, ICU. Right now I'm in acute inpatient rehab, which is an interesting thing. We get to keep the patients a little longer. I was in the military for 24 years. I was an independent duty corpsman for you Army Air Force background folks. That's a medic. Was with the Spec War guys, and I was a diver myself. I was a paramedic and EMT. See, ADD can work for you. You just don't have to pick one thing, you can go on. In any case. So, anyways, he asked me to come here. I'm one of his students now over at the college, and he thought this would be a good thing to have in your toolkits. So injury recognition and providing care. There are some things we can take care of, some things we can't. First of all, when do we assess? We're looking at and providing care. We're looking at minor injuries, things that aren't going to require or need a whole lot. Won't have to call 911. Maybe you would know are minor disabilities, no permanent disabilities. Calling 911, well, that's when the big stuff happens. Somebody stops breathing. Maybe you don't feel a pulse, or there's a significant injury like a broken bone or bleeding. We're going to call 911. When to do both generally occurs when you've tried to provide first aid, it isn't doing what you want it to do, so we're going to go ahead and make the call. When to do neither? Well, in this litigious society we've got, somebody can refuse care. They can say, you can go up to somebody, hey, I'm going to go ahead and help you, and this includes students in your dojos, and they'll say, no, I don't want you to touch me. You have to respect that. One of the things, though, is if the injury is significant enough, eventually they're going to be in a condition where you can render care because they'll probably be unconscious. Hopefully it doesn't get to that point. You're there, your students are there because they trust you and you're teaching them good things. So, now with children, a little bit different. Essentially, you're responsible for them. They have what is called implied consent, and that's the absence of a parent or a legal guardian. So medical problems. A lot of this stuff on this page is going to be, we'll call it 911 results. Chest pain could be a myriad of reasons. Could be anxiety. Got the new 60-year-old guy, he's got on your mat for the first time, and he's just overrun himself, and now he's scared because his heart rate's going fast. But you don't know if it's not cardiac. So regardless, heart attack, angina, any of these things, 911. Breathing problems, same thing. Somebody's got difficulty breathing and it's other than a simple case of asthma, and they've got their inhaler, 911. Diabetic problems. All good instructors have already gotten health statements from their students. They know who's got diabetes and who doesn't. And they know if it's manageable or unmanaged diabetes. One of the things, let's say you're at a seminar where you know each other through emails and associations, but you don't know everybody's condition. It would behoove that person to say, hey, I've got diabetes. It's managed. I got no problem with it, but if suddenly I'm unconscious, this is what they need to start looking for. Seizures. So we see seizures in a couple of different lights. One can be from trauma, an accident, taking a header out here off the stairs or getting hit in the head with a bocan. Or it could be organic, which means that there's something going on in the body, like we might be growing a tumor. Again, not your problem. Your problem is to call 911 if the level of conscious is altered. And the defined altered level of conscious, I use that term a lot. It's basically when you know your student he's Joe. Joe can answer and tell you his name, he can tell you the date, he can tell you what he's doing there. We're going to call him oriented. And if he can't answer those questions, or his answers are too slow, or he appears to be unstable, altered level of consciousness, we need to get more definitive help. Feigning. Feigning and shock kind of go together. Sometimes shock can result in feigning. Feigning essentially is the lack of blood pressure to the brain. And what's going to end up happening is the body wants to lay down or shut down. But again, feigning is a symptom. Shock generally can be caused by a couple of things, actually about 6 different things. We'll only worry about a couple here. It can be worried from blood loss, again, blood to the brain. Anaphylaxis, that's an allergic reaction to, say, a bee sting, a bug bite, peanuts. And just plain bad news. Sorry you didn't pass your Shodan test for the 5th time. Heat and cold injuries. Well, as we start noticing the sun's going down, everybody got full benefit yesterday. It dropped about 40 degrees in about 2 minutes once the sun hit the deck. And I live up over here a little ways out in the hills there, and it goes down to about 32. So recognition of your environment, training awareness, situational awareness. If it's hot, if somebody appears to be getting hot, let's say again, a new student, they just don't know their own speed, and they're going 100 miles an hour, and now they're getting lightheaded and dizzy. And they look like they might be having symptoms of a heat-related injury. We want to cool them off, bring them inside, and give them something cool to drink. Again, if their level of consciousness is normal. Cold injuries can happen out here. Maybe the first sign you'll see of a problem is somebody, again, altered level of consciousness. They're slurring their speech. But again, prevention, these are easy preventions, but if you get to the point where you're starting to see altered level of consciousness for either one of those, 911. Skin issues. I got my little funny there, fungus amongus. Essentially, this is one of the things that we deal with on a daily basis when we're teaching. If you've got mats, you got to keep those mats clean. If you've got students, you got to make sure that they're keeping themselves clean and hygienic. If somebody's got real bad foot rot, it behooves you to take them over privately, explain, hey, you need to take a look at this taken care of before we get you back on the mat. Or if there's some way around it, I've got these little sock things now that you can wear on a lot of the mats that if somebody's got a real bad problem, they can wear those. Again, if they've got open sores, any of these sorts of things, we don't want you practicing on the mat. At least until things are healed up. All right, things that we can generally do stuff about. Musculoskeletal problems. The ever popular soft tissue injuries. I've given you a list there. Contusion's a fancy word for a bruise. Lacerations, anytime that skin surface gets disrupted and open, just start to bleed. That's pretty much called a laceration. Abrasions, we've all had them. Whether it's been on the mat or out here on the gravel. Puncture, hopefully not. Amputation, that's removal or traumatic removal of a body part, won't happen out here. Avulsion. Now, interesting thing, I'll bet all of you have had an avulsion. An avulsion is a forcible removal of body tissue. And you're going, what are you talking about? Anybody ever had their toenail popped up practicing on the mat? When you come in and hit somebody else's heel because they just weren't where they were supposed to be? You've avulsed the nail. You've popped that thing up. So, and it bleeds a lot and it hurts. But fortunately, a lot of times they'll go ahead and you can put it back down and heal pretty well. Sprains and strains, basically two varieties of the same animal. A strain is any overstretching or partial tearing of muscle, and possibly tendon. A sprain is where you do the same thing, but you're doing it to the ligaments. Those ligaments hold the bones together. Dislocation and fractures, kind of along the same line as far as our ability to care for them. If you find these or somebody comes to you complaining of this, you want to go ahead and mobilize in the position you found it in. 911. The only change is going to be with fractures, you will have to do something beyond immobilizing it, is if they have what is called an open fracture. Fractures come in pretty much two flavors these days, closed and open. And there's variations on the theme. Closed fractures where the bone's broken, but the skin's intact. Open fractures where it's poking up and you got a lot of blood. Got to stop that bleeding. Head injuries, it's another one that the only thing you might see is somebody taking that fall, get hit in the head with a boucan or a joe, and next thing you know, they're not feeling good, maybe nauseated, could be lightheaded, could be altered level of consciousness. Again, not a lot you're going to be able to do with them, but make sure they're in a place where they won't injure themselves. So, 911. Neck and spine, we've got a lot of stacked little bones in our back that are very mobile, and it's not easy or not hard to overplay those and injure them. I think everybody in here has probably hurt a back or someplace your back or your neck along the lines. Same thing again, what you're interested in this is, how do you feel if somebody's taken a really bad fall, hyperextended their back, whatever, can you feel your legs, can you feel your feet, do you feel like you can move, can you move your body parts? If they answer yes to these questions, then they're a wait and see. If they start complaining of numbness, tingling, or they can't move a body part, 911. Overuse injuries, I think we've all done that. We first started practicing, especially when they put a boucan in our hands. From the cutting outwards, something called tennis elbow or lateral epicondylitis. About the only way to take care of something like this is not a 911 problem, by the way. The simple way to take care of this is rest and ice. Muscle soreness can come up to 48 hours later. Some people feel it right away. You haven't been practicing in a while, and now you're out there, you've gone to a seminar, and you want to go 100%, and you're going to hurt. Basically, it's a substance called lactic acid, goes up in the muscle body, or the muscle bellies. The body itself doesn't like acid, it burns. So one of the ways to get rid of this is stretching and massage. So if you find somebody to give you a leg or a back rub, you're all set. All right, preparation and prevention. Victory favors the prepared. So when your folks sign up, a statement of health. Again, we're seeing an older population coming into the dojo. They are, the kids have gone, they want to try something new, so let's do martial arts. Hey, Aikido looks cool. I see old people doing it. Well, it's because we've been doing it for a while. Be that as it may, they walk in and go, ooh. So statement of their health. What do pre-existing conditions do they have? Do they have previous injuries? Do they have previous experience? Are there cardiac issues? Do they take medications, diabetes? Physical fitness. We're seeing a lot more folks coming into the martial arts practice to get fit. It's more fun than a gym. So being aware of their level when they come to practice and making sure that they don't overdo so they keep coming back. So it gets to where to continue training and where to abstain from training. Obviously, if you're sick, you've got a flu, something contagious, you want to stay off the mat. And inevitably, it's going to come down between you and the student. You're responsible, the student being on the mat. If it's something like a sprain or a strain, and you feel they've got it under control, they can continue to practice. I notice some folks to go so far as to do the red tape. I think that's a great idea. That joint, don't pull on it too hard. That was pretty good. Waiver of liability, again, for the owners as well as anybody that teaches, even if it's in your backyard or in a storage space. It basically is an understanding between you and the students that martial arts are inherently risky, and you could get hurt. First aid kit, come in a variety of flavors. The sky's the limit. I mean, if you're one of these survival preppers, you can get something for thousands of dollars, but most of these run about, if you get a commercially prepared one, about $100. Myself, I'm kind of a penny pincher, so I'll go ahead and I'll adapt to things that I find. As you notice in front of you, you've got duct tape and newspaper. So we can make things out of those without actually having to buy official things. And last but not least, training. Getting CPR certified and first aid training is, worth its weight in gold. But like anything else, if you don't practice it, when you need it, you won't have it. CPR certifications are good for 2 years. Let's say you have a casualty in the dojo and it's 18 months out. You're going, what was that again? 230, 1 to 5? You see what I'm talking about. Something that can be incorporated with the rest of the students. You all get out on the mat, do some of the things that I'm going to go ahead and show you here this afternoon, or I should say this evening. All right, so we're going to start from the top down. Essentially, one of the things we see most commonly, especially practicing, especially with lateral tie jumps and stuff, sprained fingers. All right, you can dislocate them, but if they're dislocated, you're splitting them and you're out of business. But outstanding. You just paid $200 for a wonderful seminar, or you've flown a long way to go to a seminar, and you want to be able to keep practicing. So we are going to go ahead and find my supplies. There we are. And we're going to do a little buddy taping. Buddy taping is a way, and you can do it with the toes as well as the fingers, a way to go ahead and use the uninjured finger as a splint. So when you apply the tape to your partner, which you're all going to get a chance to, pull the end of it, makes it easier to come off. So we're going to say she sprained her index finger, and we want to go ahead and tape it to the adjacent finger. Basically, it depends on what joint. Again, now if it's the joint, you don't want to put these over the joint. And if the joint's involved, or I should say the long part of the finger's involved, you're going to want to splint it because it's probably broken. So you want them close enough together that they provide support for one another, but not so tight that she loses sensation or her fingertips turn purple. So now I'm going to check to make sure I've still got good circulation. I pinch the tips of her fingers, they turn white and red again, everything's great. So, all right, everybody go ahead and reach into your bags. I've got some athletic tape in there, and just tape the fingers. And we're going to apply the dressing, put some direct pressure on it. And I want to make sure that I get Lori involved here, okay? Because it's going to feel like she's got more control. One of the scariest things when you're injured is the sensation that you lost control. So once we get that, I can straighten out my much bedraggled roller.
That's cotton?
This stuff, yeah, plain old cotton. And again, so while you're watching me do this with official medical type stuff, think about what you could use to improvise in a situation where you don't have this available to you, or you don't have your first aid kit. So one of the things to keep in mind, we want to put enough pressure on it that we stop the bleeding. If it doesn't stop bleeding, we add another bandage to it. Just keep building it up. The other thing to keep in mind too is that parts of the body, especially the limbs, they aren't straight. They're all kind of cone shaped. And because of that, we need to go ahead and set these up so they don't slide off. So we're going to go ahead and wrap it around the wrist as well as around the knuckles. Sorry, this is my 4th iteration today. Say again?
How many pressure dressings do you?
How many? As much as it takes to stop until definitive care gets there, or you can deliver them to definitive care.
So do you also wrap for boxing?
I can do that. Did you bring your tape? So, you have to put your finger right there. A little bit of tape. All right, everybody, let's give that a try. Lori, if I can borrow you again. All right, so Lori got hit really, really hard. Not only did we get a laceration, but we also ended up fracturing her wrist. So, it was a tough day.
That sucks.
So we're going to want to go ahead and splint that wrist. The thing about splinting is we want to make sure we secure above or prevent movement from above and below the injury. Could be a joint, could be the middle of the bone, a long bone itself. One of the things, especially with the forearm, when we deal with putting a splint on it, is we want to make sure it's in a position of function. What does that mean? That means that our hand is not flat out, but we keep that natural curve. That natural curve can be maintained with just an ace wrap. And one of the ways to find what's a natural curve, when you let your hands hang down by your side, down like this, have a natural curve.
Yeah.
Because if they have to be in that splint for any length of time, it's going to be very uncomfortable. So, you say, well, what do we got to splint with? Man, I forgot my casting material. No, we didn't. The newspaper. Your predecessors went ahead and fixed them up for me, put a little bit of duct tape around it, and now I have a splint. What I'm going to do is I'm going to go ahead and have her hang onto that. And I'm going to take my other ace wrap. And one of the things is, if it's not uncomfortable, try and get them so the long bones are aligned. If they're either aligned like this, I'm not going to have you turn your hand all the way up, but at least in this position. Try not to get it rotate all the way over.
This way?
Yeah, like your thumbs up towards the sky. Because as you know, the radius basically rolls over the bone in there, so we don't want to aggravate it by putting more stress on that wrist. So we're going to clamshell it, and again, she can help. But notice how far down I've got it. I don't want it exposed out here, because what will happen is that joint, that wrist can still move. Here, it's not moving. I'm going to have you go ahead and finish.
So you're closing the fingers also?
All, not the tips, just most of the hand. Yeah, most of the hand. And I'm going to just take my ace wrap, and I'm going to secure it. So old newspapers, back copies of black belt, whatever. Anything that's stiff.
I can tell you, man.
Well, how much?
Stop it.
A little bit. So you can remember, your ankle got suspended. What I would be having you do is relax. And we're going to do that. That's the next thing. Yeah.
So would it either have their arm like on a table or something, or is it?
You can have them hold it at a table. Actually, what I like to do, again, we talk about patient involvement, because again, that gives that sense of control. Have them hold their own hand.
Just have them hold above.
Yep, they can hold their hand just like this. They can hold it across their belly. You just need enough room to be able to slide that newspaper on. So I'll let you go ahead and get into the mix. So let's go ahead and attempt to put a splint on each wrist. The wrist, but you know it's going to be a little while before they get to definitive care. So what's going to end up happening is we want to secure that so it's not flopping around or hanging below their heart, because that's going to cause discomfort. So putting on a sling and a swat, this is how we want to secure it. Always seems to be a little bit tricky. If you can remember, we're going to say it's her right wrist is still fractured. If you approach the victim or bring your triangular bandage with the long edge towards them, you'll never mess this up. So essentially what you're going to do is you're going to pass that underneath her arm. I'm going to have you hold on to your hand with your other hand. There we go. Right. So I've got the long end, and we're going to go, the first place it's going to go is up around her neck, and it's going to go on the injured one side. My second piece, the other tail, is going to come up and around. Now when we go ahead, you're going to want to tie this, you're going to want to have her have it up just a little bit higher. So it's just kind of like this. Yeah, exactly so, right around the heart. Go ahead and take an overhand knot in this. And we want to put the knot on the side of the neck. We don't want to put it right on the back of the spine. It becomes very uncomfortable if it has to sit very long. Okay, looks like. And then adjusting it, go ahead and let it relax. Okay, I need to raise it up. So this is what you do. They'll be working with you. Okay, that feels right, that doesn't feel right. So in her case, I'm going to go ahead and bring it up just a little bit higher.
So you want the hand higher than the elbow?
Higher than the elbow. Because if you leave it at the elbow level
Or
below, what's going to end up happening is the heart's going to cause, you're going to start having a lot of swelling from the fracture. Yeah. So, all right, so once she's got it in there, it's pretty comfortable. We want to make sure that it's not sliding in and out of this, slides off. We take an overhand knot in the tail. All right, so again, it still can move. We've just got it, we're holding it in front of her chest. So we need to secure it in such a fashion that it's not going to be flopping around. There comes the swath. They call it the swath cloth. All right, so go ahead and lift up your good arm. And we want to bring this around where, one, we're still exposing the hand. It's right above the limb involved. And we tie the knot. We want to make sure the knot's available to the patient. For some reason, they've got to take it off. They can do it with one hand. Okay, so let's everybody go ahead and try that on each other. Probably going to fall if you don't help them down. So, Lori, if I can borrow you one more time. So, Lori's acting, oh, I don't really feel good, I'm lightheaded, and I'm dizzy, and I go, can I touch you? Or can I help you? I should say, use the proper words, can I help you? And she says yes.
Yes.
All right, so I'm going to have you stand right here at the edge of it. So, but I can tell she's already going down. We're going to go ahead and put you down on the ground right now so you don't end up falling and injuring yourself. So when you let somebody down, it's just like if you've ever had any first aid or CPR training, it's basically lower it down. You want to have one leg forward, keep control the whole time. See, I'm not going to let her go, but she slide. But basically all her weight's being supported right now on my leg. And now here's the deal, when you let them down farther, continue letting them slide down, bend at the knees, let them down to their bottom. Keep your hands on their shoulder blade, keep their hands on their head, and gently lower them to the floor. All right, this way we don't do that last 2-inch clunk.
Over
their head. Yeah, people don't like that. Again, on the mats, not so much of a big deal. Something like this, very much a big deal. So why don't we go ahead and all try that on each other?
Well, real quickly, can you tell us something where there's a possibility of some kind of knee injury where you want to immobilize the knee or something where it looks like, I'm not sure if it's broken or if it's something, but they can't walk. There you go. Can't walk.
It hurts less.
It hurts a lot.
Same idea applies. Now, the issue, of course, is if you don't have anything, in other words, if you think that knee's broken or dislocated, you're not going to be the one that's going to fix it, but you can go ahead and minimize the pain. Just like you can buddy tape a finger, you can buddy tape a leg. The difference, of course, is our legs are shaped a little bit differently than our fingers. We just want to make sure we have proper padding in there. So you want to go ahead and pad out the center, and this time you're going to use straps. You're going to use 2 above the knee, 2 below the knee.
Okay.
So, and this is again a stopgap measure to make them more comfortable until the paramedics arrive.
Is it good for them to extend it or to?
Leave it in the position you found it. So if I am like this, oh crap, I'm going to bring this other leg up here and I'm going to strap it together.
Okay, all right, let's start with the arm.
Yeah.
So whatever.
And now the point is too is once I've stabilized that, now I can go ahead and roll them onto their back or wherever I need to do with it because they're not going to be doing this.
Okay.
And again,
then you call 911.
You call 911 as soon as they go, I can't get up, my knee hurts.
No, somebody else is on the phone with the 911. You calling.
You call 911. I'm strapping.
You're calling 911 and I'll deal with the
There you go. There you go. So again, there's all kinds of really cool pieces of equipment out there. Most of the stuff we work with today is training things. We talked about splint. This is something called a SAM splint. I know you remember what it looks like. Basically, it's just foam covered aluminum. And if I fold this sucker up repeatedly, I make it stiffer and stiffer and stiffer. And if I want to make it really stiff, I go ahead and put a trough in it. And now it's just like we talked about the cardboard splints.
Okay.
So a little more expensive. Myself personally, I go for the cardboard ones. When I got out of the service, they didn't want any of my equipment back, so I hung on to a lot of it. Another cool thing, and again, if you have somebody who's got a major laceration, again, I know he knows what these are. These are known as battle dressings. The nice thing about it is you have your band-aid, your thing that goes on the wound, as well as the straps to hold it down. So, and you know, it's designed for Marines. It says put other side next to wound. Or Navy guys. Anyway, In any case, you put it down and you go ahead and you make your appropriate wraps around it and tie it down tight. And the same rule applies for the stuff you were just using. If it doesn't stop bleeding, add another one. Okay, let's see, what other kind of...
What about tourniquet?
Tourniquet. Tourniquet would be for something you're having your practice up on the top of Idlewild, all the way up at the saddle, and getting help is going to be a long ways away, and you have something that truly looks like it's bleeding and you can't stop it. Then you want to go ahead and consider a tourniquet. And that's why I go back to getting trained. If something happens, they lose the limb. Probably not likely unless it's really bad. They may end up suing you. So you always have to be careful of that. Even if the Good Samaritan, you have to get that Good Samaritan rule. If it, even then, it doesn't matter. So again, training. They talk about tourniquets in this military where we have I keep saying like I was still in. I got out 5 years ago.
No,
we have a different.
You're slim.
Yeah, really. Can you tell?
You never get out.
They have a different view on tourniquets now. Actually, tourniquets are to be applied almost immediately as soon as you have a traumatic injury, and they're left on. They're finding a lot of the studies now that a tourniquet, which was the big one, you're going to lose a limb. They don't lose limbs. They're able to do a lot of reconstructive surgery with those. But again, if you've got a situation that you think you're going to need a tourniquet, do the very best you can with the right pressure, and then consider the tourniquet as a last resort. Of course, by that time you're dialing 911. Any other questions?
Neck.
Neck. Oh, good point. Actually, that was a question everybody asked last time.
Yeah.
So, patients, your victim.
They roll. They don't feel. They're on the ground.
Yeah, but I don't feel right. Maybe they wouldn't complain of neck pain, but maybe I'm having problems moving my extremities. Yeah. So I'm going to have you lie down on the ground. So this is really a tough one to do. So when she's identified she's got a problem, I'm going to say, Gloria, I want you to go ahead. I don't want you to move at all. And all you're going to do is this until help comes. You're not going to pull on it. You're not going to twist it. You're just going to make sure she's not turning it around.
You just want to make sure that she doesn't move her neck.
That's it.
Until
exactly.
somebody else calls 911 for you.
But let's say there's only a couple of you and you've got to go get something. So, hellos. They say sandbags, but who's got sandbags in the dojo? Yeah, Zafus work very good. Same idea. Want to secure it as best you can. Explain to her, okay, I don't want you to go ahead and move. I'm going to be right back. And while this doesn't give a whole lot of outright support, what it does to her is a reminder not to move. So you go do your thing and come on back. That's what we do.
That's all that's about.
That's pretty much all we can do. So,
okay.
Any other questions?
Clavicle.
Clavicle. I had the question last time too. Okay, so you've got a broken clavicle. It's either really obvious or it's broken in 3 or 4 places, and it's not obvious. The sensei told me over about somebody, I guess, they got hurt in one of her dojo. In any case, if it's angulated, that means you can see it sticking up and it's poking through the skin, just like we called an open fracture. We're going to stop the bleeding, but we're going to go ahead and sling it in place. We want to stop movement. That's one of the biggest problems with a broken clavicle is pain. So, if it's not, again, same thing. Go ahead, split in the position you found it. Sling and swath works really good. If it's going to be a while to the definitive care, you can put a little bit of ice on it, but not too much. You want to take it off every 5 minutes. So, and that's another good question, because we have a tendency in this art to use a lot of ice, in our own selves or recommending it for other people. Put ice on. You want to leave it on for no more than 10 minutes, take it off for 10 minutes, put it on for 10 minutes, because ice is really interesting. For 5 minutes, it's going to act what they call a vasoconstrictor. It's going to keep the blood flow from going to the body part and numb. After about 5 minutes, those vessels go, hey, we might end up with frostbite. They open up. So that's why if you do the frozen bag of peas and it's all bright red, that's all that blood going back to that joint, which is what helps the healing.
So 5 on, 5 off.
10 on, 10 off for the ice.
Okay.
Anything else? If you have any further questions or something you want to talk about or forgot to ask me here, on the very last page, I'm trying to put together a little bit of a business. You can email me or call me. I'll be more than happy to answer questions.
Right.
So I think dinner time's up. And
Okay, thank you.